Very good evening, one and all. Uh, this is OS webinar series of Vidya, Vandate, Amritam. The theme is ocular trauma, and this time we have cases from neuro-ophthalmology and strabismus. I welcome our President OSOS, Dr. Srimant Kumar Behera, to kindly welcome all the expert panel and the speakers and moderator. Over to you, sir.
Friends, this is the second webinar series of OSOS, and this is nicely taken up by the scientific committee and present to the members of OSOS. I welcome all the members of OSOS. Please participate and enjoy the scientific extravaganza. Now, we are also having the expert panel from the AIOS, Dr. Rohit, Dr. Jyoti, Dr. Virendra, Dr. Mahesh Kumar. I welcome them. They have spent their valuable time and to join in the webinar. Last but not the least, I cannot forget to talk about Dr. Ajit Babu Maji. He is the mentor, he is the guide. I like him very much. We have got a very good relationship with him, and he has come and joined, and I thank him. So let us enjoy the scientific extravaganza, and over to Sir Mr. Madam.
Thank you, sir. Just a few lines about this program. The vision behind this webinar is it's designed not just as a standalone event, but as a part of larger effort to integrate different generations of ophthalmologists to bring together stalwarts from across the country and talents from within the state. It ensures a dynamic learning environment where our faculty and residents get the best exposure to all contemporary advancements. Over to Dr. Devasmita Maji. She will be moderating the session. Over to you, Devasmita.
Thanks, Dr. Samistar. So, good evening, dear all. Good evening, all our OSOS members. I want to just welcome our expert panelist. That is, we are happy that from all different four organizations, the expert panelists, they agreed to help us and teach us regarding the neuro-ophthalmology component and the strabismus component involved in the ocular trauma. So we welcome Dr. Rohit Saxena, who is the professor, the head of the Department of Pediatric Ophthalmology, Neuro-Ophthalmology and Strabismus from AIMS Delhi. So welcome you, sir. Dr. Virendra Sachdeva, who is from LV Prasad Eye Institute, who is heading the campus at JMRV. He's head of the Pediatric Neuro-Ophthalmology and Strabismus Department of LV Prasad JMRV campus, and he's the network head for the Neuro-Ophthalmology Department. Welcome, Dr. Virendra Sachdeva. Welcome to Dr. Jyoti Matalia. She is heading the Neuro-Ophthalmology Pediatric and Strabismus Department from the Bangalore Narayanetra Lab. So welcome, ma'am. And Dr. Mahesh, who is heading the head of the Department of Neuro-Ophthalmology, Pediatric and Strabismus from Arvind, from Madurai. So we welcome all the four experts who are experts in the neuro-ophthalmology department, who have their lot of contributions in the publications, in the national and international forums, and they are all very good teachers. Along with our expert panelist, Dr. Vivek Warkar, who is heading the LV Prasad department and Bhubaneswar, the pediatric neuro-ophthalmology and strabismus department. Welcome, Dr. Vivek. So Dr. Priyadarshini, she is from the Neuro-Ophthalmology Department of AIMS Bhubaneswar. Dr. Sweta Dhiman from JPM Rotary, and Dr. Ruby from the Apex Eye Care Cuttack. Here, all the eight, they are expert in their own field. Hope today's discussion will help us to throw more light on our ocular trauma concept. So, why we have chosen the concept of ocular trauma now? Because nowadays in our routine OPD also, we are facing lot of cases from the road traffic accident, starting from the young age to the old age people. The various ranges of ophthalmic trauma where a globe is involved or the orbit is involved, with or without muscle tear, with or without involvement of the optic nerve, with or without involvement of other cranial nerves. So through the today's discussion, we will learn about how to manage these things in a protocol basis and what should be the priority of a surgeon or a physician while managing the cases. So, with this background, let's start from today's topic with Dr. Durga Sahu. She is a pediatric fellow from LV Prasad Eye Institute, Bhubaneswar campus. So, Durga, we welcome you to start your first case. So, her first case will be based on the involvement of muscle tear and the optic nerve in a case of trauma. Up to you, Durga.
Okay, thank you, Dr. Devasmita. Thank you, everyone at the outskirts. I would like to thank you, OSOS team, for giving this opportunity. I hope my slides are visible and I'm
Yes, Durga.
yeah. Okay. So this case I have titled "Bad Tear Can Go Wrong, but Good Decision Can Do Miracle." So before starting this case, whenever we see strabismus in cases after trauma, so there could be three possibilities. Firstly, it can be related to nerve palsy or the traumatic neuropathy, which can happen. Second is there can be any muscle entrapment which can happen due to the trauma that because of the orbital wall or the fracture. So the muscle entrapment can also lead to strabismus. And third, and the majority of the cases where we see that the strabismus is because of the affection of the extraocular muscle. So in this case, we'll be catering to the third component, which leads to the strabismus. So let's begin with this case. So this story is of a 35-year-old gentleman who came to us in an emergency OPD with a complaint of right eye redness and left eye sudden blurring of vision associated with diplopia, pain, redness, swelling, and protrusion of the eye along with the limited ocular motility. He had a history of road traffic accident under alcohol influence, and he had trauma in the left eye with metal rod happened 4 days back. So there was a history of loss of consciousness following the accident, and after he gaining the consciousness, he noted that there's a diplopia with pain and the limited ocular motility in the left eye. So the where he was primarily managed, he underwent the CT scan, and which were suggestive of the zygomatic fracture and the orbital medial wall fracture in the left side, and there were no signs of muscle entrapment or the extraocular muscles were visible in the cuts. So on visual assessment, the right eye had a visual acuity of 20/25 with near vision of N6, and the left eye had a 21/25 vision with near vision of 6/12. The color vision demonstrated the defective color vision in both eye, left more than right, and there was a sluggish pupil response in the right eye, and there was a grade 2 RAPD in the left eye. There was a fixation preference with the right eye, and the on examination, you can see here the right side face has a multiple abrasion and the temporal fullness with subconjunctival hemorrhage. And the left eye, there was a lower lid edema and mild proptosis. And there was no obvious abnormal head posture. And as you can see here, that the left eyeball was deviated outwards and upwards. And the proptosis we can see here in the worm's view in the lower image. On anterior segment, this was post-dilated. The pupil were normal. There was no anisocoria as such. So right eye, we just can elicit the subconjunctival hemorrhage, whereas in the left eye, you can see that there was a conjunctival congestion and chemosis with a conjunctival tenons laceration in the inferior quadrant, and there was a necrosed conjunctival tissue and the subconjunctival hemorrhage. Apart from that, the cornea had abrasion and the epi defect with mild haze. And there was no sign of globe rupture as such. And in this standard +9 gaze, you can appreciate that there was approx 50 prism diopter of exotropia with 30 prism diopter of left hypertropia. Apart from that, there was a gross ocular motility in all gaze in the left eye, while right eye just had a abduction limitation of -1. So at this point of time, for all the viewers, just a minute pearl, which can be taken from this is, it is very easy to underestimate the deviation in traumatic strabismus because the patient might be under pain, so he will not. The pain, because of the pain, he will not, might not attempt full movement. So that is one point. And second point, that in examination, saccadic velocity also help us to evaluate the potential contractile power of the muscles. So moving back to our case, in the posterior segment, we can see the disc were healthy. The two images were like the magnification was different. So the left seemed to be like slightly pale, but it was not like that. It's shown in the image. The disc were absolutely normal. So at this point of time, we made a diagnosis of left eye acquired exo and hypertropia status post blunt trauma with the suspected medial and inferior rectus tear. Yeah. And also, he had a traumatic optic neuropathy, which was elicited by the visual acuity and the color vision. So, the plan was to cater both the traumatic optic neuropathy and the strabismus part. So, for the TRON, we went ahead with the 3 dose of intravenous methylprednisolone. And then for the left eye, we planned for the on-table exploration of the medial and the inferior rectus along with the flap tear repair. And beforehand, we explained the patient regarding the chances of under and over correction and also the chance of post-operative diplopia and the need of resurgery in future. So let's go through this surgical video. So before going ahead, first and most important thing is that in cases of trauma, avoid doing FDT because we are not sure of the status of the muscle. So it's better to avoid FDT. So we started dissecting the conjunctiva from the inferior quadrant where it was the laceration, and we tried to identify the inferior rectus. So in cases of trauma, make sure that whatever tissue you feel like is a muscle, make sure that you secure it. Later we will see whether it is the muscle or not. So we went ahead with securing the inferior rectus and we cut off the necrosed conjunctiva. So here you can see the distal inferior rectus stump. And the similar manner, we tried to dissect the medial rectus. We identified the rectus and try to separate with the 60 vicryl. And as we identified the proximal and the distal end of the both inferior rectus and medial rectus, we identified that the inferior rectus which we are holding was actually not the inferior rectus, and we might have lost the inferior rectus in the orbit. So on table, we decided to do an inferior oblique nasal transposition since we lost the inferior rectus. So, and the distal stump of the inferior rectus was chopped off. Similarly, for the medial rectus, we secure the medial rectus near the insertion of the distal stump, and the distal end of the medial rectus was decided to like chop off. So this gave a resection effect as well. And then the betadine wash is very crucial in cases of trauma with exposed conjunctival laceration. And finally, then the conjunctiva was opposed with the help of 80 vicryl. So this summarized the overall surgical step. First, we identified the medial rectus and the rectus. Then we dissected the inferior oblique because we were not we lost the inferior rectus in the orbit, and then we went ahead with the medial rectus attachment near the distal end, and then the conjunctiva was opposed. So this was the post-operative 2-week follow-up where we can where we can see that there was a gross improvement in the deviation which was there, and the eyes look fairly aligned. And apart from that, the visual acuity, which was the baseline, we can see after the uh, 3 doses of intravitreal IVMP and the oral steroids, there was marked improvement in the visual acuity as well. So the at 2 weeks, we just had a 8 prism diopter of exotropia with 6 prism diopter of hypotropia left, and then the extraocular motility was grossly improved. And this was the 1 month follow-up. The vision further improved to 20/30 and the color vision also improved. The pupil reaction became normal. So this is the last, the 1 month follow-up, which we had. The patient has almost like orthotropic with just flick exotropia for near, while ortho for distance. So there are, on reviewing the literature, there are multiple reports which suggest the similar presentation of inferior rectus and the medial rectus. So the reason being the inferior rectus commonly affected in the cases of trauma being firstly because of their closest approximation to the limbus, the insertion site, and second because of the protective bells phenomena. Whenever they met such trauma, the eye has a tendency to close. So when we close the eye because of the pelvis, the eye goes up and out, exposing the medial rectus and the inferior rectus tendon to get affected. So the key takeaway from this is avoid FDT in the cases of trauma because we are not sure of the muscle, whether it is torn, whether it is attached. So in the attempt of doing FDT, we might lose the muscle in the orbit. Second, ensure all fibers are identified. Thirdly, on table uncertainty, so expect the unexpected. And removal of the dead and necrotic tissue is must, and the good apposition of the proximal and distant end to be made. And then the betadine watch at each step is crucial to avoid post-operative infection. And the patient should be counseled well before the surgery about the unpredictability because it is also a surprise for the surgeon intra-op. And the follow-up for the residual skin and resurgery should always be explained to the patient. So here is the outcome from our large 50 exotropia and large hypotropia. The patient become almost ortho in the final visit. So at the end, the patient was happy, the doctor was happy. So this came to end of my presentation, and I would like to put forth question to the panelists that how to manage the resection effect of cut necrotic tissue first, and second, give us some tip and tricks on retrieving the muscle lost in the orbit.
Yeah. So thanks, Durga, for the very nice presentation, and thanks, Dr. Vivek, for the nicely managing the discussion with Dr. What process to managing the resection effect of the necrotic muscle. Dr. Rohit, am I audible?
Okay, right. Sorry, I missed you a little there. Firstly, congratulations, Vivek team, on a wonderfully managed patient. Just one or two questions before I thought we'll go for discussion. Did you wait for the IVMP3 dose before doing the surgery, or was that done simultaneously as you started the IVMP?
Yeah, so basically, on day one, I started immediately the IVMP, and meanwhile, took the anesthesia fitness, and next day I took the patient for surgery.
Sure, great. So, I mean, that's what I wanted to highlight. Whenever you have a trauma like this, you go in as early as possible, the moment you get fitness and all. And of course, IVMP would help. Any steroids would help to reduce the inflammation. And I think, again, wonderfully managed. Uh, um, uh, I would also say, I mean, like it's really not a flap tear; it's a complete transection, as has been mentioned in that. One more question, Vivek, did you get a chance to do any imaging prior to your entry?
Yeah, actually, the patient had already had imaging done. So there I was pretty sure, that the extraocular muscles, they were very close to the globe. So I didn't repeated the MRI as such to specifically, the plan for UMS, because ultimately I was pretty much anticipating that we need to explore on table and take a call. Yeah.
Right. Again, a good orbital imaging MRI could, help in anticipating flap tears and, of course, fully transected muscles. Because what happens is, if it's completely transected, the proximal part, which is separated from the globe, comes like a clump nearer the apex.
Thanks.
or else you can see a clear indication, clear discontinuity. But obviously sometimes you don't get because of inflammation, edema, hemorrhage around the muscles. So and in a day or two, why did you resect that medial rectus part? Why could you not have kind of resutured it to the
Yeah.
stump of medial rectus you saw?
Yeah, because that stump was the very small length, and it was kind of the macerated. So I was anticipating if I try to the suture it, then it will cause cheese wiring and I might lose the secured medial rectus. So I chose that, and anyway, like the patient had a exotropia. So even if
Mhm.
I lose that much part of the muscle, I would have even more kind of the resection effect. So that's what I was trying to contemplate and do that. And I think that was luckily worked.
Right. So,
Yeah.
I mean, I would just say that I mean, like, that's the first step if you can preserve the tendon and resuture it. But yeah, if it's macerated or if it's very small, then probably it may be better to mildly just recess and overcome the effect of resection and just suture the muscle there on the sclera. I think wonderfully done. uh, Searching for the muscle in the orbit is, an absolutely terror job. Surprising that the medial rectus could be found and the inferior rectus could not, because the inferior rectus has attachments. But then again, if it was injured far posteriorly, then there is likelihood that it would have cut through and through with all its attachments and gone. And the medial rectus probably may have had some attachments and may have remained not too far away from the site of rupture, and that is why it was. But like I said, I mean, again, not do FDT, not try to move the globe, not try to rotate the eye. Make sure you have good exposure. Neatly open the conjunctiva gently. Make sure that the assistant is not pulling tissues away. Use gentle lens hooks to open up the area where you anticipate the muscle. Try to pick up whatever tissue you can, and then, of course, work from there. Wonderful job done, Vivek. I think it was an excellent outcome. Again, showing good meticulous planning can go a long way in giving good outcomes.
I have a small doubt. Can I ask Dr. Durga?
Yeah.
You said whatever you get, you first suture. Later on, you
Yes.
confirm what muscle it is.
Yeah.
Please explain.
Actually, whenever like you, if you have the suspicion that this might be because we are not sure the muscle has torn where it is went. So like you just make sure that like whatever you are holding, if you feel like it's a muscle because you can see the muscle fiber, just secure it, and then later we can see whether with like in our case also with the hold it, like we first thought that it was inferior rectus, but later we found that it was not. So just to have a confirmation, like we might not lose the tissue which were holded first, so later like there is no harm in securing that.
Okay.
I think by securing, she means just to pass a suture and make sure that the tissue doesn't fall back, not
Okay.
suture it onto the sclera. So you hold the tissue and you
Yes.
pass a kind of a traction or a stay suture through it, so that later on you can, if you can pull it a little and try and explore and identify whether it's the muscle or some other tissue, not
Okay.
necessarily, suture it to the sclera.
Dr. Vivek, I have a doubt. On day one, you got the MRI. What was your expectation? Which muscle is lost and how much it is lost? That is
Yes.
number one.
So basically, the patient had, the scan done outside, and here I was pretty much confident, being the inferior rectus, I would be able to catch it up, because most of the time it get entangled in and around the inferior oblique. So inferior oblique is a safeguard to the the inferior rectus. However, I was pretty sure probably I will the probably not able to retrieve the medial rectus, but on scan the MR was very much close to the globe. So I was confident, okay, let's try. And I had kept, the backup of oculoplasty guys around while doing the surgery in case, I'll lose the muscle in the orbit, probably, especially the medial rectus. I'll take their help. So inferior rectus, we tried to search a lot, even, bought into the oculoplasty specialist. So we, after working on almost 30, 45 minutes, we decided, okay, there is no logic in looking at the IR. Although we know that, when the IR doesn't work or we have operated also patient with lost IR and, the infrarectus aplasia. So nasal transposition of inferior oblique works very well, because when you transpose the oblique nasally, then it acts like a depressor, and that exactly, and it's a very strong procedure. That's how, you see the depression has improved almost normal post-operative.
Last modules in trauma is very common, and you need to hunt the module sheet. Once you get the sheet, automatically following that and retrieving the module becomes much more easier. If you see the pictures, preoperative and postoperative, preoperative, it is very obvious proptosis is there, whereas postoperative inophthalmic eye is there. So what could be the reason for that inophthalmos?
No, I think that that's not an enophthalmos. That's a mild ptosis which is giving this appearance. And even preoperatively also, that's a relative proptosis, because, the two muscles, they got probably detached. So the eyeball is, there is nothing like something push forward mechanism, and that is a true proptosis.
One on the preoperative
Sometimes in
scan,
these cases, like the inferior oblique can also give a indication to where the inferior rectus is. Sometimes if we are not getting the inferior rectus, we can hook the inferior oblique, because the fibers of the inferior rectus are usually underneath the inferior oblique. So if at all there is a resection which has not gone posteriorly and some fibers are there in order to retrieve the muscle, that is one more indication that we can do.
Actually, there will be some running fibers between these two modules that also can help us in retrieving inferior rectus.
So that's very good point, Ruby has highlighted. That's how I was trying to, look on the either extent of, the medial and lateral extent of whatever the horizontal oblique I could secure. Is there any fibers? But unfortunately, that was not the IR.
Yeah, it's very tough in trauma. We can easily discuss, but on the table, it's always.
It's very difficult.
A little bit of enophthalmos can occur because of fat necrosis and damage to the vascularity in a very severe traumatic case like this. So the initial exophthalmos, as Dr. Vivek pointed out, could be because of the disinsertion of the muscles, although there may have been some hemorrhage also in the retroorbital area. And then once that resolved, and there may have been some fat necrosis or loss of fat tissue, there may have been that mild enophthalmos that may be there.
Rohit, do you advocate excision of macerated tissue, or on the table you give a benefit of doubt in some cases? Unless it is very necrotic, you made a reset. Otherwise, half macerated, probably it's good to give a trial of leaving the tissue, and then that it may regain viability.
Absolutely. I mean, that's why the initial question of when we went in for the surgery, and as Vivek pointed out, went in early. So the aim is to enter as quickly as possible, so you reduce the chance of these tissues becoming non-viable because of lack of vascular supply. So a day or two, you can still possibly manage to work on them. But yeah, if the tissue, whether it's muscle or something, is lying exposed outside the conjunctiva because there is a lot of lacerated conjunctiva, then you may have to think in terms of whether you want to risk orbital infection or not. But yeah, you try to preserve all bits of tissue as much as possible, muscle and conjunctiva particularly, because later on you may have restrictive strabismus developing because of shortage of conjunctiva or shortage of the tissue. So yes, you go in as early as possible so that it also reduces the risk of the muscle slipping back. It may get damaged or lacerated, but it often remains there in that position. The longer you wait, that likelihood of the muscle slipping back into the orbit increases. So as early as possible.
So one more thing I would like to add is when you see this patient clinically, we should always have the suspicion of the muscle probably being torn off. As strabismologists, we'll be able to pick up. But otherwise, before you advise an MRI, it's always best that when we are suspecting this, ask for the orbital cuts as well. Because we just normally, a neurosurgeon or neurologist will just get it done from the point of view of the brain or traumatic optic neuropathy. But we specifically ask for this because as strabismologists, we would like to go in and check whether can we really retrieve, like as you could find it, you will be able to pick it up. And secondly, this when you're doing a nasal transposition of inferior oblique, sometimes a small resection can help because that will further improve the amount of depression that it helps. But a very good case, Vivek, you did a very good job. So it was really nice.
Dr. Jyoti has mentioned that on the fourth day of giving IVMP for drawn cases, will it work or not? What is your experience as it is on the fourth day?
Yeah, true. So actually, if you go according to the Cochrane review, they say that anything more than 8 hours does not give anything. But then keeping in mind the benefit of doubt, you discuss with the patient. So if there is a possibility, no contraindication from neurology, if you can give, there is always no harm in giving. And in this patient, the vision was not significantly low. I mean, we're talking about patients who come after 4 days having PL, PR, we're not really sure whether it is. And neuro and the MRI may show there is significant already incisions or damage to the optic nerve. Here it was relatively decent. So I feel in this case, benefit of doubt and give the IVFP. However, I'm not really sure whether the steroid really worked or it's a natural cause. But when we know that there's a TON and vision is not too less, there is no harm trying to give a IVMP for these cases.
Smita.
Can we go to the next case, Dr.
Yes.
Devasmita?
Yes. Yeah. So Sutakirti, we'll start with Sutakirti's case. Yes, Sutakirti, you can start. Go ahead.
Good evening, everyone. Am I audible and are my slides visible?
Yes, yes.
Slides. Yeah.
Slides now.
Slides not yet. Yeah.
Are they visible now?
No, ma'am. You need to share those,
Not
please.
yet. Not yet.
It is
Yes.
coming now, but we need to wait.
Is it visible now?
Yes, yes. Yeah.
Shall I start?
Go ahead. Yes.
Full screen mode.
A very good evening to one and all. Today I will present a rare case of orbital apex syndrome, which was a sequelae to traumatic frontoethmoidal mucocele. As we all know, orbital apex syndrome is characterized by vision loss, ophthalmoplegia or paresis, periorbital pain, ptosis, proptosis, with or without diplopia, hyposthesia of the forehead, and diminished corneal sensations. The etiologies are varied, starting from infectious, traumatic, inflammatory, iatrogenic, and vascular. Traumatic orbital apex syndrome is a rare but vision-threatening complication of the facial trauma, which occurs because of the compression of the neurovascular structures as a result of the direct impeachment from the osseous fragments which are fractured, any hemorrhage, foreign bodies, or any significant edema. The small anatomical size of the orbital apex and the confinement of the critical neurovascular structures within this limited space makes it highly susceptible to injury. A brief anatomy of the orbital apex. It is the posterior part of the orbit at the craniofacial junction where the four walls converge, and the contents are that of the optic canal, including the optic nerve and the ophthalmic artery, and the contents of the superior orbital fissure, as we can see here. So coming to the case proper, a 45-year-old female presented with severe drooping of the right upper eyelid, protrusion of the right eyeball, along with diminution of vision in the right eye since the last 15 days. She gave no history of any head or ocular trauma in the recent past, no history of systemic comorbidities, and no history of fever or sinus infections in the recent past. On ocular examination, her best corrected visual acuity was counting finger close to face and less than N36 in the right eye, and 6/9 parts N6 in the left eye. Color vision could not be done in the right eye, and it was normal in the left eye. She had a severe ptosis, obiaxial proptosis, lid edema, diffuse conjunctival congestion with moderate chemosis in the right eye. Along with that, there was a yellowish vascular mass which was overhanging from the right upper lid. Cornea had an inferior corneal scar in the right lid, and there was early senile cataract in both the eyes. The right eye had a grade 3 relative afferent pupillary defect. As we can see here, there is a severe ptosis with moderate proptosis, lid edema, and this conjunctival congestion and chemosis. On modified Krimsky, 20 prism diopter of right exotropia with 35 prism diopter right hypotropia was found. and there was this gross motility limitation in all the gauges in the right eye. Left eye had a normal motility pattern. We did the dilated fundus examination for the patient, which showed frisson grade 4 disc edema with multiple phlegm sept hemorrhages, peripapillary arenophyll edema, and retinochoroidal folds in the right eye, and left eye had a temporal pallor. V-scan of the right eye showed deformation of the posterior ocular cords with multiple retinochoroidal folds. Coming to the laboratory parameters, there was a high ESR and CRP with neutrophilia on the differential count, and urine microscopic shows few pus cells. Then we did the neuroimaging for the patient. Here we can see on the contrast enhanced MRI brain and orbit with contrast on the T2 weighted coronal and the axial scans. There was a peripherally enhancing hetero-intense lesion, which was 4.5 into 2.3 into 2.7 centimeter in the superior part of the right orbital extracorneal compartment. It was extending posteriorly to the orbital apex, as we can see here, and medially to the lamina papyracea. This was causing the stretching of the right optic nerve. This lesion was also iso to hyperintense on T1 weighted coronal and axial scan, and it was displacing the eyeball inferolaterally. A similar lesion was also noted in the right ethmoidal sinus. So this was suggestive of an extracorneal space-occupying lesion, probably a right ethmoidal or a frontoethmoidal mucocele with retroorbital extension. Then, as we have a multi-specialty hospital and we have that privilege, then we consulted the ENT people, and our ENT specialist did a nasal endoscopy, and they found a right DNS with a high spur. They also ordered the CT-PNS, which showed soft tissue density mass lesion in the right retroorbital space, which was causing the outward medial and inferior displacement of the right eyeball. There was complete ossification of the right ethmoid sinus with expansion and bony defect of the right lamina papyracea. So with this, an impression of the large right frontoethmoidal mucocele was made. With these clinico-radiological findings, we came to a probable diagnosis of right orbital apex syndrome secondary to a frontoethmoidal mucocele with retroorbital extension and both eyes senile cataract. The patient was urgently referred to the neurosurgeon. Under neurosurgery guidance, which started 3 doses of injection methyl prednisolone, followed by the tapering doses of the oral steroids, along with oral neurovitamins. After the completion of the 3rd dose of the injection methyl prednisolone, the patient was taken off for bifrontal craniotomy with cyst excision and decompression, along with the cranioplasty under general anesthesia. But the intraoperative findings were very surprising because the cyst only had a dark colored fluid. The cyst wall and the fluid were sent for biopsy and histopathology. It was suggestive of inflammatory cell infiltrates with no atypia, and finally, the diagnosis was organized hematoma, mostly traumatic. The culture reports came to be sterile. So what was the cause of this frontoethmoidal mucocele? After further questioning the patient on revisiting the history, she revealed as having an episode of blunt trauma to the right forehead and the eye with a tree trunk 2 years back. But she was very casual about that. So she had not told this in the prior history. And this was managed by the local ophthalmologist with topical lubricants and antibiotics at that time. After that, she was asymptomatic. So after all this, we came to a final diagnosis after reviewing the literature, as we came across various cases of orbital apex syndrome, which is secondary to any traumatic paranasal sinus mucoceles. So our final diagnosis was a right orbital apex syndrome, secondary to traumatic frontoethmoidal mucocele with retroorbital extension. On postoperative day 5, there was some improvement in vision with slight improvement in the ptosis, proptosis, and she was able to read the demo plate on the color vision chart. There was also some improvement in the exotropia, right hypotropia, along with motility limitation. At postoperative 1 month, there was significant improvement in the vision. The ptosis was only mild with a mild proptosis. The pupil was only had a grade 1 RAPD in the right eye, and there was minimal right exotropia with right hypotropia with a minimal of -1 limitation of the elevation. Rest of the motility pattern was normal. Postoperative 1 month, she had a temporal pallor in both the eyes. So coming to the discussion, paranasal sinus mucoceles, when long-standing, can erode the thin cranial bones and orbital bones, leading to orbital and intracranial extension, which can lead to permanent visual and neurological sequelae. On expansion of these mucocels, they compress the optic nerve and the adjacent structures, resulting in orbital apex syndrome. The frontal and the ethmoidal paranasal sinus mucosals most commonly cause the orbital apex syndrome because of their close proximity to the orbit and the optic nerve. The proposed mechanism is cystic dilatation of the sinuses, which is secondary to the obstruction of the sinus ostium. That can be because of any allergy, any infections, trauma, or any iatrogenic surgical interventions in the nose and the paranasal sinuses. Post-traumatic obliteration of the ostium of the sinus leading to mucosal formation is very rare, which was seen in our case. A short review of literature shows that there is paucity of literature of large case series as well as articles. There are only few cases reported in literature where we can see a paranasal sinus mucosal caused by a trauma and the latent period is very high, like from days to years together. Similarly, a case by Hassan et al. Which was reported with a giant mucosal of the frontal sinus caused by the frontal bone fracture, which was 30 years back. And this patient was managed with cyst decompression, cranioplasty, and hydrosteroids. And the postoperative outcomes were good. Similarly, Sokri et al. Reported a 21-year-old female who was diagnosed with traumatic orbital apex syndrome post-RTA caused by direct compression of the displaced fracture. And this patient was also managed similarly, and there was significant improvement in the vision. There are other similar case reports of the traumatic frontoethmoidal mucosals which affect the optic nerve and the orbital apex, causing a significant decrease in the vision and other manifestations of the orbital apex syndrome. As we can see here, the latent period from trauma to the manifestations of the orbital apex syndrome is very large. It is like mostly 30 years, 19 years, as we can see here. And the most common paranasal sinus involved in literature shows it to be frontal followed by frontoethmoidal. There are other case reports of delayed this post-traumatic mucosal formation in the frontal as well as frontoethmoidal sinuses, which can lead to vision-threatening complications. So, my take clinic message would be frontoethmoidal mucosals or paranasal sinus mucosals are benign lesions of expansive character. If they are left untreated, they cause local, orbital, and intracranial complications, which can be vision as well as life-threatening. It is very crucial for the ophthalmologist to be aware of the ocular manifestations which are associated with the sinus mucosals so as to avoid misdiagnosis and delayed diagnosis. Because many times ophthalmologists are the primary physicians who come across these patients. If we cannot diagnose the signs and symptoms or ocular manifestations associated with these conditions, then the patient will ultimately land up in vision and life-threatening consequences. Early diagnosis through a combination of ophthalmological examination and radiological techniques, as well as prompt and appropriate referral to the concerned specialist like the neurosurgeon or the neurologist or the ENT surgeons, along with the timely interventions, are very pivotal in preventing the alarming consequences. Thank you.
Yeah. Thanks, Shrutakirti. Before going so you want to answer that first? Because the trauma was 2 years back.
I think we lost you in the middle. I'm sorry.
For Sutakirti, hello?
Hello, am I audible now?
Yeah, Sutakirti.
Yes,
Yeah.
ma'am.
So there is a question from Dr. Samista. How is the injury 2 years back is related to this mucosal? So do you like to answer first this? Then we'll go to the panelist questions.
Yeah, actually, the patient initially gave no history of any trauma. There was neither any history of any infections or systemic comorbidities which would have caused this paranasal sinus mucosal. So then we again revisited the literature and we saw that there is a long latent duration between the trauma and this formation of this paranasal sinus mucosals. Usually what happens, this paranasal sinus mucosals, they erode these orbital bones and then they spread intraorbitally as well as intracranially. So after having a lot of research, we could not find out any other cause for this development of this paranasal sinus mucosals apart from the trauma. And it has been seen that trauma 30 years back or 49 years back could also lead to this kind of paranasal sinus mucosals, which would ultimately result in vision-threatening complications or neurological sequelae, as we found out in our patient.
Okay. Dr. Virender, we want to first ask you that do you encounter such cases of orbital apex followed by trauma that can be due to the paranasal sinus mucosis?
Um, Thanks, Dr. Devsmita. Thanks to the Kirti
Yes.
for presenting the case. Uh, I think this combination of having both the paranasal sinus mucocele and causing orbital apex syndrome is described. But to say that it is occurring definitely due to the trauma is a little concern, and maybe like as Shrutakiri just pointed out that on revisiting all the relevant literature as well as reprobing the history, trauma was the only associated history. So might be that would be one of the triggering factors, but many of the times the etiology is not clear in these patients. So they might be traumatic orbital, there might be orbital apex syndrome due to paranasal sinus mucoceles, especially the posterior ethmoidal mucoceles, because they are very close to the orbital apex. We have seen a patient recently also which had both afferent as well as efferent component involved, but there was no relevant forthcoming history of the trauma. So I would say that it is possible. These do occur. They are uncommon cases, but at the same time, to relate to trauma, I think we should keep in mind that trauma could have occurred and the injury overall blocked the ostium and the things accumulated. There are other relevant histories that might be there, like history of uh, uh, frequent
URIs.
infections and chronic allergy that might be important. Dr. Rohit, you
So,
have seen anything like traumatic OS due to
yeah.
PMS?
So I think Virendra, a very interesting case and very nice. I'll just make out one or two points. I mean, as Virendra pointed out, uh, it's not impossible. It's just that the ostium should get obstructed due to any reason. The more common ones being recurrent URIs, infections, allergies. So chronic allergies, particularly if a person is from a rural background, they may have allergies, and that may anything that obstructs the ostium will predispose to the development of this mucocele, which would slowly enlarge. And if the person does not, so it's more important to ask questions of recurrent URI or nasal blockade or things like that. But I mean, I'm sure you may have asked for it, and rarely, as you have shown in literature, there may be that some trauma may have damaged that ostium or that area of the mucosa there, and that may have caused it to close, and gradual development of the mucocele may have happened. I just wanted to make a couple of comments. I would say that I would refrain from actually calling this traumatic orbital apex syndrome. One, the trauma directly is not responsible for the clinical manifestations that we are seeing. It's very remotely related to that. And secondly, I would say it's more than just the orbital apex syndrome only. I mean, classically, whom we define orbital apex would be ones that are lesions that are essentially limited, localized to the orbital apex. So they, like in this case, there's very significant proptosis. Usually, we would not have. I mean, like it's called orbital apex because it's kind of an identifying, localizing lesion that visual involvement, loss of vision, along with some or significant motility difference reduction may present. Very rarely they may have mild proptosis, but that severe edema that you showed, the significant proptosis, one would say that it's now completely orbital infiltration rather than limited to just the orbital apex. So I would say that, I mean, like you would rather call it as an orbital involvement than just involvement of the orbital apex. And I mean, you've asked the question about IVMP, and I thought about it also. I was like wondering, why would you want to give IVMP in such a chronic, slowly progressive condition? Uh, the vision loss is actually compressive, and the lesion has reached fairly anteriorly, causing compression of the venous drainage, which is causing that severe disc edema. So the earlier you do the decompression, after that, maybe you could think of giving steroids orally, or I mean, again, IVMP may not be, or 1 gram methylprednisolone may not be necessary. but yeah, steroids to reduce the orbital inflammation and swelling. But the faster you reduce the compression, the more likely you would get visual results. But of course, this was a chronic case, so I those comments. But again, very nice, very important to localize the lesion, to identify, and as you mentioned, you need all ENT as well as neurosurgery to manage these complex cases. You can't just limit it to the ophthalmic purview only.
So thanks, Dr. Rohit and Dr. Virender. Dr. Mahesh, we want to hear from you. In your experience, have you come across such kind of cases? And if we don't have the ENT's specialty there, then being an ophthalmologist will immediately refer the patient or manage something and then will send the patient. Because as Dr. Rohit said now, that here IVMP should not be the priority and decompression should be the priority.
Thank you for the question. So I have seen similar case of frontal mucosales, traumatic frontal mucosales, which have caused superior oblique palsy because of the close proximity to the tendons, but not exactly in this manner. So I would, if it is a traumatic orbital apex syndrome, I would imagine a direct trauma to the orbital apex causing, just like Dr. Rohit said, causing the restriction of all the ocular motility. So similar case I have not seen. Having said that, it is not entirely impossible. One thing I'm concerned about giving IV methylprednisolone is how sure are we in eliminating an infective cause in such cases? So even though the radiologically it may suggest mucosales, but how much sure we are in we can positively eliminate an infective cause. So those steroids might help in a lower dose in the surgically, but as Dr. Rohit said, in such a high dose, it may not have been warranted. That is my thought about it.
Yeah.
Thank
you, Dr.
We had
Mahesh.
a case of actually a nasopharyngeal carcinoma, which like recently we had seen a patient where within a week's time, because of the very aggressive nature of the lesion, it had spread from the nose to the orbital apex, and there was a complete loss of vision. Patient was PL negative with all movements restricted. After the patient underwent chemotherapy and radiotherapy, there was an improvement in the movement, but the vision did not improve because once the nerve has been involved, this is like that would be an infiltrative type of nerve involvement. But in this case, because the nerve has not been infiltrated, probably the vision is improved from CF to 624. Like that's a very good improvement in the vision.
Ruby, do you think it is because of IVMP? Because I feel it's mostly because of the decompression, the vision has improved.
Yeah, I think the first thing is to remove the compression on the optic nerves before it is actually going into like a pressure related. If you are trying to decompress it, it will immediately start showing improvement. And then, as they discussed, if you want to then add steroids to reduce the inflammation, could be done later.
Yes.
The chronicity of the damage would be leading to the permanent damage, and the chances of recovery would be lesser. There's something other interesting in the MRI images if you can project the gateway. So if you look at those MRI images, the coronal sections, the second image that is showed, it does not appear to be continuous lesion between the medial side and the supratemporal side. So might be that also is little challenging to explain that whether it is the same thing or it's an extension from the. If you see here, the first picture, the second picture, you can see a large lesion heterogeneous, which is there, and then it is not contiguous with the ethmoidal mucosal over there in the last image. So maybe that there is another component there.
And what would the hematoma signify? Whether there was a hemorrhage into the mucosal which has led to the hematoma and that has progressed the mass, the symptoms which has happened before 15 days, or there's something else?
Something has happened on a more recent basis. Was there a relevant history like that, Sudhakirti? Maybe we missed that portion.
No, Dr. B.S. There was no such history actually. There is no history of any relevant change prior to having this episode 15 days back.
What was the histopathology, Sudhakirti?
What was it?
Histopathology. You have removed the
histopathology. Yeah, the histopathology showed this inflammatory etiology with no ATPR, And only there was presence of the RBCs and the polymorphonucleus cells. That's it.
No, no, no. The mucosal, if you are coining it as, there should be some layer which is should have been present. Did you look for it or not? Everyone, we are assuming that it is mucosal, and then rest of the discussion follow only mucosal, but histopathology is the clinching. So what was it?
So actually, what happened that was a organized hematoma. When the histopathology they did, that was suggestive of an organized hematoma. What they wrote in the histopathology report.
Yeah, that is
I think
mainly.
what Dr. Ajit wants to say is that an injury 2 years ago and enlarging mucosal is unlikely to be having an organized hematoma
Exactly.
2 years later. So again, Dr. Virender was also pointing out that there may have been something. So, I mean, something has resulted in a bleed into the mucosal possibly. So we need to look for those causes of that sudden presentation of that. Again, these are just a few cuts. Ideally, we would like to see maybe on a CD so that you can, continuously scan the entire orbit and see whether there is any place where they are actually connected. And two, as Virender was pointing out, it's more important for us to know why they are presenting now. Gradually progressive history, we know patients often come late to us, possibly yes, but a 15-day history, something has happened acutely to a probably chronically increasing lesion, which is resulting in this acute presentation and that hematoma that we are seeing. So the hematoma means that 15 days or a month ago, there must have been some bleed into this. So we look for trauma, localized trauma, minor injuries also, or blood dyscrasias or something which may have resulted in the bleed there. And because these are not erosive, so it's not happened that it has kind of ruptured a vessel or the ophthalmic vein or anything. So these are very slowly progressive. So something has happened to bleed to result in a bleed. So the etiology should be kind of searched there also. I think that's what we all are kind of wanting to know.
And the
Yeah,
ESR is
when
60.
we came across when we came across the case, we also tried to elicit the history, like whether 15 days or 1 month back she had any history of even of any trivial trauma, but she was not able to tell that she was having such an episode. So that was the thing.
The ESR is 60 in this patient.
Yeah, ESR was high and CRP. Yeah,
How do you explain that?
that was a chronic inflammation going on. So
No,
because of that, the
no, no, no.
SCRP.
Each parameter is equally important. See, the thing is, if you are given a topic, you will present very well. But here, ESR, why it is 60? It is high. It's an indirect indicator for inflammation. But are there any lesions which are causative for this raised ESR in the body? Probably this is localized, which probably not related.
Also,
But she had
neutrophil
no other
you are
system.
saying is
Yeah.
around 86. So maybe there is a acute infection which has happened over the chronic infection or something like that. Because at
Maybe.
present, I think you said neutrophilia.
Yeah, she had a neutrophilia, like 83%
Yeah.
neutrophils on differential count. But she had no, like on the CT-PNS or on the nasal endoscopy, she had no features of any acute or chronic sinusitis. So that in a matter ruled out.
So maybe Sutakirti, the patient may need another systemic evaluation if comes. Maybe post-op,
More
the patient will
evaluation,
come to you
maybe.
definitely. So proper systemic evaluation by
So
physician
while
is required.
going through the literature, actually, I came across one interesting thing that there is production of the cytokines by this lining of the fibroblasts of the mucosals that promotes the bone resorption and the remodeling, which causes the expansion of the mucosal. And when the expansion has sufficiently come and it undergoes any intraorbital or intracranial extension, then that causes the symptom. And there have been cases of acute, like this presentation in a few, 2, 3 cases where this traumatic paranasal sinus mucosals, they have caused the acute presentation like this.
Yeah,
And
yeah,
in
it
one
is
case, there
possible.
was hemorrhage into the mucosal.
It is possible. A very big lesion is there, so acute change might have happened, and that is contributing to all the things if we have extensively worked up and ruled out. But possibly, is there any other trigger? Is what we were also trying to find out. Are we missing anything, or was there something else that could have accounted for?
I will try to find out when the patient comes for the next follow-up. We'll do a total, like all the investigation, further investigations.
Dear panelists, we'll go to the last case because Durga has another case. So, Durga, can you just present the case quickly?
Before
It's
going
an
to
interesting case.
I just had a one query regarding this case.
Okay.
Did we did there is a possibility of having CCF when she had trauma? Because in one of the picture, like where there was a corkscrewing of the conjunctival vessels also. So might be there is a apart from the mucocele, she might be having some low flow CCF.
But if you'll get the CCF, Durga, there will be prominent superior ophthalmic veins, which we can see on the MRI. But there was no such prominent superior ophthalmic veins. Okay. And also
I
there
think it
can be
was probably because of the venous outflow compression by the enlarging orbital tumor. So just like we saw discedema, the central retinal vein may have been obstructed, compressed, causing that discedema and those hemorrhages. I think that may have been also responsible for that congestion, anterior congestion and the conjunctival congestion we were seeing.
also that condition that yes, that compression is also leading to the prominent, that is retinochoroidal folds, which we were able to see also in the fundus, and
Because
the
of that large
deformation.
tumor pressing. Yeah, because of the
Deformation
large
of the
mass of the cell.
posterior ocular cords also we saw on the B scan. So that was because of that only. But there was no prominent superior ophthalmic vein on the MRI. So this ultimately ruled out CCF.
Also, CCF has more of pulsatile proptosis type of.
Proptosis, yes.
That is one
Although
of
low flow may not
might not.
necessarily. Low flow may not. So it sometimes, that's why it's sometimes missed.
Missed.
And you need to identify just on those basis of slightly enlarged vessels on the conjunctiva. So it is, but a very nice case, very interesting case, and I'm sure as you will work up and you follow up, we'll learn a lot more about understanding these cases. Wonderfully presented.
Yeah, Durga, you can go ahead and
To the
request
third
to
case
go.
today's session. So here I'll be catering to the component where the nerves have been affected, and that is the cause of strabismus. So we'll learn about the management of the traumatic sixth nerve palsy through a case-based approach. So before we move ahead, like what we need to know, like we need to do in cases of managing the traumatic sixth nerve. So first and foremost, which we all know, that we need to watch for the spontaneous resolution, and the waiting period should be approximately of 6 to 9 months. And the assessment of the residual muscle function in the follow-up that can be done by the force generation test, and also the FDT to identify if any extraocular muscle contracture, the antagonist contracture that can be elicited. So management after a waiting period. So what we have to do, the initial strategies, it includes like during the waiting period, we can advise patient to have a monocular patching to avoid diplopia temporarily. And also we can advise prisms. And the third option is the Botox, which can give a temporary relief from the diplopia which the patient might be having. So after that waiting period is over, so when we evaluate the patient, if the patient is having some sort of residual function of the lateral rectus, so the options which we have is for the partial sixth nerve palsy, either we can go ahead with a medial rectus resection or a lateral rectus resection, or a combination of both, depending upon the amount of the deviation which patient is having. Or we can have an option of resection and resection in one eye with a contralateral medial lateral resection in the other eye if the deviation is large. So but now if there is a total sixth nerve palsy, like even after waiting for about 6 months, we didn't get any resolution. So what are the options which we have? So first, like there are various procedures device over the time, and we talk about the Hemesham procedure, where They have transferred like half tendon of the vertical rectus, the superior rectus and inferior rectus has been transferred to the near the lateral rectus. Then the Jensen's procedure, where they tied to without dissecting the vertical recti, they just split the fibers of the lateral rectus and they tied to the vertical recti so as not to compromise the vascularity. And then the transpose in vertical rectus transposition, we can do a complete or partial or a Foster modification, where apart from transposing, we will we'll suture these muscles to the rectal rectus with the Foster augmentation suture. And then the Nishida procedure, which we all are very well aware of, where like the splitting, we will not disinsert the vertical recti, we will just split the rectis and then we will attach it just approximate to the lateral rectus. And over time, this was by Pradeep Sharma et al., where they have devised a novel, they have made a modification to the Nishidas. And here they, apart from the decision of the lateral rectus, this procedure actually, they just change the direction of vector force of the vertical recti without splitting or tenotomy of the muscle. So it's called modified transposition myopexy. And then by the Mandela et al., they have described the superior rectus transposition and medial rectus decision for the Duans and the sixth nerve palsy. And we have a in-house publication where we have reported a study of 15 eyes of 13 patients, which was managed by the superior rectus transposition alone, along with the medial rectus recession in patients with sixth nerve palsy. So here you can see that the mean esotropia was around 56, which improved to the residual of 10 post-operatively. And they have found out with that augmented superior rectus transposition along with the medial rectus recession, they managed the cases very well. And even the large deviation remained stable over a long period of time. And but in few cases, they noted that this transposition induced vertical torsional, the component of torsion has been induced. So coming to the case proper, so this is a 47 years old male who came with a complaint of diplopia since 3 days following a road traffic accident. And he was primarily managed in the AIMS Bhubaneswar, and then where the neuroimaging has been done and it was normal. His best corrected visual acuity was 20/30 in the right eye and 20/25. The patient was a known case of high myopia and he underwent LASIK surgery in both eyes. The anterior segment and the posterior segment were unremarkable, but on orthoptic evaluation, you can see here that he has a very large abnormal head posture with a 30-degree of left face turn. And in Hirschberg, there was around 35 to 40 degree of esotropia. The reflex was just inside the limbus. And on cover test, it was about 70 to 75 prism diopter of esotropia with gross motility abduction limitation in both eyes. So this is the 9-gaze picture depicting a -6 abduction in both eyes, while rest of the motility was normal. So an impression of large acquired esotropia in bilateral traumatic sixth nerve palsy was made. And as I already told that was a high myopic with had undergone LASIK surgery. So we move ahead. So we thought of waiting as a protocol, like we have to wait for a period of at least 6 months. So we advise for a monocular occlusion to avoid this diplopia and to get rid of this large angle AHP. And then we followed patient eventually, and then the final, the follow-up at the 6 month, we noted that there was no change in the deviation, and the limitation motility was status quo. So we went ahead with the surgery of we planned for both eyes medial rectus recession and superior rectus transposition to lateral rectus of both recti of both eye. So this is the representative surgical video where we can see. So first the conjunctiva is the opening is made, and then the lateral rectus is the superior rectus is being secured. the tip here is like before like securing and taking out the superior rectus from the insertion, we can do a mild cautery at the insertion site. So as you can see here, the mild cautery has been done very gently at the insertion of the superior rectus, and then the superior rectus is been secured. And like when you dissect the superior rectus, make sure that dissect it to the posteriorly with the surgical sponge, and then make sure like to place a a 50 Dacron on the superior rectus before transposition, before taking out from the insertion site at around 14 mm from us, and then after this, the superior rectus has been disinserted, and then the lateral rectus is also been secured, and you can see here that the this Dacron suture has been passed from around 14 mm from the limbus, and then the superior rectus and the lateral rectus will be opposed together by while taking a scleral bite here. So at the end, the two muscles are like opposed together. And so this change the direction of the superior rectus vector, and thus help in moving the eyes to the abduction. This will help in abduction and will help in correcting the esotropia. And moving ahead. So this is the post-op 6-week post-surgery follow-up. So here we can see that how the large the face turn has now become there was no AHP at this presentation, and there was a residual esotropia of around 16 prism diopters with 6 PD of hypotropia for distance, and for near he was he was almost ortho. So the abduction limitation also improved from -6 to -3. And then for the residual esotropia, the patient was having diplopia, so we referred to the orthoptics clinic for the PRISM trial. And so here you can see the impact of the superior rectus transposition for an extra large deviation. So from 30° to 30° left face turn to no AHP, and like from 70 prism diopters of esotropia to almost like 16 prism diopters with markedly improved abduction limitation. So with the PRISM trial, the patient was doing good. And so what we learned from this case is that any suspected traumatic 6 nerve, always look for any ocular cause of motility limitation. Rule out like a rule of thumb. In all cases, we have to advise for the imaging. So we do need to do the orbital wall, rule out the orbital wall fracture, any muscle entrapment. And sometimes the orbital hematoma can also lead to this limitation. So that also need to be ruled out before labeling it to be a pure nerve-related palsy. So the wait and watch is the rule. And then for the extra large deviation, as in our case, we can see that the superior rectus transposition of the both eyes worked very well. And the residual strabismus and diplopia can be taken care by the PRISM trials. So the question to the panelists, I would like to ask, like, what is their opinion and experience regarding the Botox injection in such cases? And have you any experience of the torsion induced by the transposition?
So, yeah, thanks, Durga. We'll request Dr. Jyoti to opine in her experience whether she have used Botox injection in cases of this traumatic 6 nerve pulses till we are waiting for the surgical correction.
Yeah, so usually in cases of traumatic, I do give Botox. I give it to the medial rectus and allow time for it to heal. And it really works well. Giving it earlier works better. So within about 6 weeks of presentation, if you're waiting, then it is best to give it. If you plan to give it after 2 months, then the effect is not as good as you get because there is some sort of contraction that comes in. But I have given it in patients. So when we know we're going to wait, especially in cases like this, where we know the recovery is going to take more time. Like in ischemic cases of 6 nerve, we know it'll recover faster and the resolution is better. But here we know sometimes they don't improve as well. Botox is a good injection which you can give to the medial rectus and give some time for it to prevent a contracture. So you get a little better I mean, the eyes don't go fully into adduction. There's some better improvement in your adduction and abduction. So I always prefer Botox when I'm waiting for any of these cases. But I would always advise to give it in the early, within the first 6 weeks, so it works better.
Okay. And the surgical procedure, will you like to follow the same as Dr. Vivek has used here, SRT or any
So
other
I
procedure?
I feel lately I've been doing a MR recession along with a modified
Hello?
Nishida of hello, you can hear me, right?
Yeah, we can.
Yeah. So I have been, rather than doing disinserting SRT and I have also done a modified Nishida. But what I do here is, first and foremost, it's important that you break your attachments of the SR completely so you're able to move it. And then rather than doing it 12 millimeters is what we've been learning from the modified, I'd go as close to the lateral rectus. It's like almost in augmenting it, and then I get the better effect. However, this is depending obviously on the deviation. If I feel that is significantly more, then yes, we can look at the option of doing an SRT. But I have got good results with MR recession along with the modified Nishida involving the superior rectus. But it's always important that when you are doing that and you have decided to do the MR recession first, followed by SRT, always do a FDT on table. You'll know how tight your muscle is. Once you have finished recessing, see the tightness. And then when you decide to do the SRT, balance the tightness of your MR where you have placed it along with your SR. So you exactly know that where your eye would be eventually post-surgery. So this is what I tend to follow.
Okay. Dr. Vivek, you want to open on this torsional component. Like, have you experienced this torsion after doing the transposition?
Yeah, you are asking me, Devasmita?
Yeah, Dr. Vivek. Yeah.
Yeah, so I think, this particular case was not a simple case. It is a very severe form of, the sixth nerve palsy with a very gross abduction limitation. So normally we don't come across such a severe form, and that's how, we usually get away with by doing kind of just MR or MR plus SRT, or sometime, the SRT alone. But again, how severe the nerve injury, that would decide, how gross the abduction and primary gaze deviation. So in the first go, I was, not very confident in taking this patient for Botox, because with such a gross, the abduction limitation, sometimes it's very difficult to catch hold the MR and give the Botox very much precisely into the muscle, avoiding other complications. That was one thing. And the vertical deviation was the problem for this particular patient. If you go to that the PRISM trials, so the patient was very happy, the kind of the primary deviation before surgery he had and post-operatively. So his field of vision has improved, but he had some sort of the torsional diplopia. So you go back to that slide, Durga.
Yeah.
And we have our the optometrist with us, Soni Singh. So she was actually taking care of this particular patient in orthoptics clinic to help him to get rid of his torsional diplopia. Soni, can you hear us?
Yeah, good evening, everyone. Good evening, sir. Yes, sir, I can hear.
Yeah.
Hello.
So,
Am I
yeah.
audible?
Yes.
Yes,
Sir.
sir.
Go ahead.
Yeah, in this case, as sir has told, was a very difficult case, because we have seen this case in like when he presented and he had a very severe AHP and he got even the getting neck pain and other things. So once he was corrected, the surgery was done. He was quite happy, but there was some residual double vision, and he was IT professional. So he was having so much of difficulty doing in his like the laptop works and other things. So we went ahead with the PRISM trial, and where we had to give is because there was both vertical and horizontal deviation. So we trial with both Fresnel and compound prisms, like where we fuse both the horizontal and the vertical deviations, and then we give one either by splitting. If we are giving the ground prism, we split among both the eyes, and if we are giving the Fresnel prism, we are giving one eye. So in this case, we gave the prism glasses, and then he was like, he followed up quite 2 to 3 times again, and then he was quite comfortable and happy with the glasses. Although there was a little bit of AHP was left, but he was able to manage his work. Hello.
Yes, please go ahead. We are able to hear you.
Yes, sir. That's all from my end, sir.
Yeah, so basically, these cases, it's very difficult to make the patient happy in all aspect. Although, the we have had a remarkable improvement, but sometime, these PRISM trials, they would help them in both the ways, like psychologically also, it's kind of, the kind of placebo effect. Along with that, what they have come along the long journey. So that's what from my end, but I would take, the opinion from Dr. Rohit, because he does almost all patient, I guess, the modified Nishida, and what is his experience in dealing with these patients?
Thanks, Vivek. First, congratulations on a wonderful case. I think I would have planned similarly. Can we go back to the 9 days?
Yeah.
I was just wondering that I saw a bit of a V pattern in the pre-operative period. So, I mean, I don't know what was the torsion in the post-op. So, could there be a mild SO under SE? I could see if you see this, there is appears to be a V pattern in the cases. So, although there appears to be a very slight SO under action in the left eye, I'm not sure about the right eye. So, of course, if such a mark ESO that maybe, I mean, obviously we can't be very, very sure, but sometimes we do see in these traumatic cases a V pattern developing over time. Even in a few ischemic, I have seen over time a small V developing, not necessarily due to the obliques, but possibly due to the medial rectus, because the medial rectus starts getting contracture and tightness, and that's why it causes that kind of V formation or tighter pulling inwards as the eye goes down. So that may be one of the reasons. Although sometimes in trauma, you're also looking at a superior oblique underaction, which we kind of can miss because of the massive esotropia that the patient has. So, just a couple of things I would want to point out to a wonderfully done case. Maybe I would do stage one eye at a time. I would do medial rectus recession with an SRT with a posterior fixation suture in one eye, and the other eye, considering this large deviation, I would probably put the medial rectus on an adjustable with the SRT with posterior fixation. So possibly we could have reduced a little bit the amount of post-operative esotropia, but it can be difficult. Early Botox may help, but in traumatic cases, as Jyoti was saying, often they don't recover so much. So really, in ischemic, it makes a huge difference because it allows the recovery of the lateral rectus while the medial rectus is paralyzed. So good effect post-op, but yeah, in the long term, but traumatic may be good or bad. Like in this case, it may not help so much, but prevent a medial rectus contracture. So I would do that. The only surgical difference, or when we were talking about torsion, so one reason why we sometimes get torsion is when we do not dissect the frenulum that is between underneath the superior rectus and the superior oblique. So when we transpose it, I always, before pre-surgery, I try and dissect as much, but you want to be careful on the nasal side because you have the superior oblique going and you don't want to cut the superior oblique. But once you have transposed and sutured it onto the adjacent to the lateral rectus, you explore that nasal part and you make sure that the superior oblique fibers return to their original position. So sometimes if there is a drag, then the superior oblique is actually pulled forward. So you've kind of, advanced the superior oblique and made the superior oblique a little tighter. So as Vivek was saying, extensive dissection is very, very important to as far back as possible, particularly on the nasal side of the superior rectus, to prevent this uh, superior oblique being pulled, and that may be responsible for the torsions that sometimes we may see in the post-op. I mean, we've done a lot of SRTs. In fact, I still prefer SRT to anything because I feel that superior rectus transposition with a posterior fixation with a medial rectus gives us almost 45 prisms, or so we had done a kind of systematic analysis of all transposition procedures. Although when we had done Nishida was not so much popular, so we didn't compare it so directly with the Nishida, but almost 45 prisms, give or take a bit, you can get by this procedure. So again, a very well thought out, I think, surgical planning. Nishida, I feel, again, because we haven't head to head compared it, I feel may give a little less effect as compared to an SRT, although you're doing two muscles, but the amount of transposition or the directional change is on the lesser side. But MR recession becomes an important additive because, one, more often than not, you have contracted muscles on the medial side, and weakening the antagonist always helps, I think. But wonderfully done, Vivek. I think a great outcome to a rather complicated case.
Yeah, so I think what I completely agree with Dr. Rohit. Initially I was thinking about, am I dealing with, the traumatic fourth nerve palsy? That's how it was giving the, the perception. But, being such a, gross abduction limitation, I was not able to pick that up, on a cover test that there is subtle, the left vertical deviation. But then after surgery, it was kind of manifesting, and I completely agree with that. This nasal fiber dissection in the posterior orbit is very important. Not let the oblique to, move towards the transposed, the SR, and that's how that gives more kind of tightness effect, and that induce the torsion.
Sir, I had two questions. One is, sir, what was the FDT and FGT in this case? Like, did you before surgery, was there any this thing? And second thing, that this, as you mentioned, this patient is a high myope. So, did you find any difference in the muscle pulleys? I mean, sometimes there is a heavy eye syndrome which happens in cases of
Yeah,
high
so
myopia with
that
esophageal.
was very much into my mind, like, are we dealing with kind of a myopic strabismus fixus? But it was not, that range of, the high myopia. He had 8.5, 9 prism diopter of myopia on in his old records, number one. Number two, in this particular case, MR was super tight. It was like +4. It was super tight.
And maybe the MRI before surgery, because it is a trauma case, and MRI must have been
Yeah,
they have a
MRI was done.
right.
MRI
So
was
myopic
done
strabismus
in AIIMS Bhubaneswar, so that would recruited partner.
yeah. So I think there is Dr. Sarmista is asking about role of IVMP, but mostly in traumatic nerve palsy, sixth nerve palsy, we don't give IVMP. Dr. Vivek, you want to comment on that? Anything? Role of IVMP?
Yeah, I think there is no role of
Role of IVMP.
IVMP for cranial nerve palsy, although our, the neurologist friend, they are very fond of giving, if not IVMP, then at least, the oral steroids. But I mean, I don't believe on giving IVMP. In fact, we should rule out something gross in the brain and rather try to avoid, the undue use of steroids.
Steroids.
One question I have, there's a patient I have who had something like this, a bilateral sixth nerve, has got operated twice in both the eyes. Both MRs have been disinserted and they put behind. Both eyes SRT has been done, and the eye right now is 100 PDET, no abduction at all. Eyes are completely stuck in, and both eyes SRT done, and both eyes MR recessed twice each eye. So basically 6 surgeries have been done. So I want to know if anybody has any opinion on trying to hook the LR insertion onto the orbital wall. Rohit, do you?
Yeah,
Means basically turn the globe. You're putting attractions. How we do it for an for a third nerve, where we put the MR onto the orbital wall just to get the eye, because the eye is like this, and there is not even, it's like -8. Already operated. Yes, we'll have to go and check if the FDT is tight, and you have to recess the MR if there is. But it's been operated twice in each eye, with SRT done to the lateral rectus with augmentation, but there is no movement. Absolutely. So the idea of shifting basically turning the globe like this, so basically losing traction. Anybody has any opinion on whether anybody has done that, or
yeah,
how would that?
I think you can think about, the periosteal fixation of the globe to the lateral orbital wall, and
Yes,
you can
that's what I.
let the medial rectus loose into the orbit.
Hmm. Anybody has done that? Anybody has any experience? Rohit?
No, I haven't tried that. It's an interesting thought, although the only downside of that is that, those traction sutures that you're going to place in the orbit and to the insertion of the lateral rectus may actually show through on the lateral cancers, because all these things are, the moment you see here, you may. Medially, everything gets hidden because it's going straight posteriorly. Here, it's going a little laterally. So it may not, but yeah, the angle is too large to be able to manage by a bilateral lateral rectus plication, however amount. Um, yeah, a difficult thought. I mean, I don't know. I haven't tried it, so I can't, tell you. I mean, you don't need to touch the lateral rectus for this. So this could be
Yeah.
a fail-safe. Like I always say, the medial anchor is a fail-safe for me for any third nerve palsy. So maybe this would be a fail-safe. You could try a very, very large bilateral lateral rectus plications. And if they don't work, then maybe you could think in terms of putting one orbital, sutures, because you'll need non-absorbable sutures, and the
Yes, yes.
chances
And
that
to
they
go
may
and
pull
tell you.
through they may just pull through. So difficult. It's a very difficult, case to manage. Yes.
Dr. Jyoti, I have done it for, the very large hypertropia. So it was like,
Mhm.
360 hypertropia, and I fixed the globe to the inferior orbital wall, and it worked very well. So that was a one-eyed patient, it was very difficult to rehabilitate, and that fixation helped to have, the good vision, at least bringing, the cornea into the visual axis, and that's how the patient was able to see. So I
So
think
we
it
also
was
did
a
it
bad
Eight-year-old
for
time.
child.
similar condition. We put in, put a plate here, fixed a plate here, and then tied sutures to the plate. Uh, that was done fairly long time ago. We had described that. But yeah, to the lateral orbital wall, you can put, screws and tie from there. So that's, as Vivek is saying, that's a possibility you could think of if you want to. But I mean, the risks are that the suture is likely to give away over time. I mean, it's a tough case to manage. I would grant you that.
Long-term stability also will be tough to get.
Yeah.
Just to add to the discussion on the torsion and the Botox, maybe since there is a residual ET, we could still try in the recessed muscle. It might help relax the muscle a bit and might lead, though the effect may be temporary. And just to add that, since SRT is considered as a is a imbalanced transposition as compared to a complete VRT. There are reports which describe that there can be torsion, though fortunately in our experience we have not had subjectively manifest torsion before, but at the same time it is described and people have described methods to prevent it. Intraoperatively they mark 6 o'clock, 12 o'clock limbus and then monitor it during the sleep. So this is also one point I wanted to add for benefit of audience.
Thank you. Yeah, Dr. Mahesh, you want to add for all the three cases?
Thank you, doctor. I'm not able to add anything on the strabismus part because I'm not a strabismus surgeon. However, one point I would like to recollect from one of my cases in a traumatic sixth nerve palsy is any worsening of a sixth nerve palsy following trauma. Please reevaluate the case because we have seen one case of delayed onset of CCF, direct CCF. So there is a worsening of the sixth nerve palsy, and the patient insisted on reimaging actually, and the patient insisted we always need to listen to the patient. Patient insisted that it is getting worse. Then when we reimaged, we found a slowly trickling direct CCF evolving. That is one point I would like to make and for the postgraduates to remember. That's it from me. Thank you.
Even in a delayed presentation, that could be the cause.
Yes.
Okay. I think we are already late. So thank you everyone for some very nice discussion. So now I hand over the thing to Dr. Salmista.
Thank you,
So,
Dr.
ma'am.
Devasmita. Can we, I request a team mentor to kindly play the video if it's there. Hello?
I don't have the video as of now.
Okay. So thank you so much. So I thank one and all the expert panel. I thank our mentor, Dr. Ajit Babu Maji sir. I thank moderator, Dr. Devasmita. Both speakers did fabulously well, Dr. Durga and Dr. Sutakruti. And I thank our support team and all the participants who took part here. And I would like to openly admit that I was so scared of neuroophtha always, and today has been very good, really, and lots of take-home messages as well. Thank you, all the expert panel.
Thank you for the opportunity. A
Thank
wonderful
you.
symposium.
Thank you and good night.
Thank
Good
you.
night,
Thank
sir.
you.
Thank you.
Thank you. Good night.